I know idea. So I'm going to just do some background about what a rehabilitation psychologist is. So, and then hopefully I can entice you to join us and help us. All right. So let's get started. All right. So, hi everyone. My name is Dr. Hammond. I am a rehabilitation psychologist. I am board certified, and today we're going to talk about chronic illness and disability and how we can provide intervention, specifically CBT mindfulness, but I'm going to touch on a few other things as well. I do not have any conflicts of interest. And so today's outline, I'm just going to go over the background of what is rehabilitation psychology. I think it kind of doesn't get a lot of attention. Most people know of neuropsychology or cognitive psychology, and a lot of other psychology is developmental, but they don't know or haven't heard a lot about rehabilitation. So I'll talk a little bit about that. I'll talk about disability as diversity and the importance of understanding that. And then we'll jump into the aspects of intervention. So, cognitive behavioral therapy, mindfulness, and maybe some more interventions in primarily 8 different areas of competence. And then hopefully I'll have some time for questions and open it up to you guys and see what is interesting or, what you want to know about. All right. So, what is rehabilitation psychology? Um, According to APA Division 22, which is rehab psychology, it is the application of psychological knowledge and skills on behalf of individuals with disabilities and chronic health conditions in order to maximize health and welfare, independence and choice, functional abilities, and social role participation across the lifespan. So we're really talking about a lot of different areas across the individual's life.
Dr. Hammond,
Yes.
sorry to interrupt. I don't know if your slides are supposed to be changing, but for us, we're just looking at the first slide.
Ooh, that's not good. Okay, so I'm going to exit. Does it look different now?
We can see the outline
Okay,
slide.
you can see the outline slide. Interesting. Okay, so I may have to give it from this like without the presenter's view. Is that okay?
I think so.
Do you see it now? Like
Yeah.
what is rehabilitation psychology?
Yeah.
Okay. All right, so we're gonna have to do it this way. My apologies. Apparently presenter view doesn't want to cooperate. All right, well, we'll try it again, but thank you for letting me know. Um, so this is a definition of rehab psychology, and basically it's sometimes I find myself as a rehab psychologist doing a lot of things that I never thought a psychologist would do. And so we will talk a little bit about that as that goes on as well. Um, but you can see that we touch on a lot of different areas of an individual's life. So, what kind of diagnoses do rehab psychologists see? So, I see everything from traumatic brain injury and disorders of consciousness. So, a traumatic brain injury or somebody who has a disorder of consciousness would be somebody who was potentially in an accident and hit their head, and maybe now they're in a form of coma, or they're emerging from a minimally conscious state. And so we work heavily with folks who are coming out of these areas and are trying to regain their lives and re enter the community. Um, and then we also work a lot with folks who've had a stroke or acquired brain injury. So, acquired brain injury is sort of like an umbrella term that captures stroke, but we often talk about stroke separately. But because acquired brain injury also means anything like brain tumors or potentially any kind of injury from some sort of illness or other disease process. Um, and so it encapsulates a lot of things. Traumatic brain injury is really a unique phenomenon that has its own separate trajectory and a lot of different challenges that stroke and other acquired brain injuries may not have. So you have to kind of separate it out from that. But other diagnoses that we see are spinal cord injury, and this could be like a traumatic spinal cord injury, or it could be acquired, meaning somebody could have had like a bleed in their spinal cord, or they could have been in an accident. We also see people who have lost their limbs for a variety of different reasons. It could have been, again, an accident or some trauma, but it also could have been from a disease like diabetes. Burn injury is a particularly unique specialty that I don't do a lot of because those rehab psychologists primarily work on a burn unit. Um, but I have had some experience, and it is very, very challenging, but it's a highly specialized focus. We also work a lot with chronic pain, which I imagine that you guys see quite a bit of in the community as it's a very common issue. Neurodegenerative diseases, so that's like ALS or Parkinson's or dementia. Um, Neurodevelopmental disorders. So I don't work with children, but individuals who do specialize with children work more in this area. And then also we do a lot of polytrauma, so meaning that somebody who has a whole host of various injuries from whatever incident or accident or issue they face. So they could have had like lots of surgeries and limb loss and brain injury and a whole host of other things going on. All right, so we see a lot of really challenging presentations. But who are these patients or clients? And so I may flip back and forth, just so you know, between patients and clients because my primary place of work is at a hospital, so I'm very used to the term patient. But in outpatient, obviously, I think it's preferable to use client. It's a preference, but so I just want you to know that I might flip back and forth between those words. But we serve not just the individual, but their families, their larger social networks, as well as their medical and rehabilitation teams. And treatment sometimes focuses on like a mental disorder like depression or anxiety or PTSD or something like that. However, a lot of times it's adjustment that's really intertwined to the physical injury or the illness or functional change that has occurred. So sometimes it'll be like also like a health behavior change, like limiting the amount of alcohol use or something along those lines. But it's not always just a depression diagnosis. A lot of times our patients don't even know that a psychologist is coming to meet with them. And in some cases, they literally have no interest in meeting with a mental health professional, which makes it really challenging when you walk in the room. So definitely you meet a variety of people at different stages of adjustment to their injury and illness. So where do we practice? You will see us in a lot of different places. So if you can imagine somebody is in a car accident, they may be emergently taken to the hospital and be admitted to the critical care unit. And if they have a traumatic brain injury or disorders of consciousness or something like that, a rehab psychologist might come there to evaluate them. I happen to work in acute, that next one, acute inpatient rehabilitation. So after people are medically stabilized, they often come to an acute inpatient rehabilitation after the car accident, for an example. And then after they get better from an acute stay, which is usually 2 to 4 weeks. If they need more treatment, sometimes they go to what's called a subacute place for ongoing treatment. But then there's outpatient, which is where you guys are. And so you might find patients that have been through all of these stages. They might be coming to you in a specialized clinic for pain, or they might be involved in like a transition program, or they might, where they have like a community liaison. So we provide intervention throughout the lifespan, but sometimes it could be just a couple of visits over a few days, or it could be somebody's entire life in an outpatient setting, which is where you are more likely to see these folks. So let's talk a little bit about disability as diversity, because I think this is a really important topic. So Dr. Erin Andrews from the Academy of Rehabilitation Psychology is an expert on this and wrote a fantastic book. And so if you're interested in this, I really encourage you to look her up. She's a fantastic speaker. And she talks about how disability is really more of a cultural experience and not just merely a medical status. And that kind of idea will be throughout the rest of this presentation, that disability is really defined as one's cultural, personal experience rather than just a medical issue. Because Dr. Andrews talks about the impact of ableism. And if you're not familiar with ableism, ableism is a set of beliefs or practices that devalue and discriminate against people with physical, intellectual, or psychiatric disabilities. And it often rests on the assumption that disabled people need to be quote unquote fixed in one form or the other. And we'll talk about this because the idea that something needs to be changed or fixed is highly individualized. And you may find that your client or your patient is really content with how they are, and that he or she may not need to fix anything. And so that's something to consider. The book also talks about the importance of disability identity development, because some individuals readily identify as being disabled and they really embrace the disability community, which is really highly active at many times. But others don't view themselves as disabled, even though they may meet what's considered commonly held or accepted criteria for disability. And as I speak about disability, you may notice that the language changes, and there are several controversies about this. So there's a lot of discussion between what's called first person or identity first language. And so first person emphasizes that the person before the disability. So someone who is blind or someone with a spinal cord injury. Versus identity first puts the disability in the description, so disabled or autistic. And according to the movements within the disability community, either one is equally appropriate depending on the individual's preference. So at this time, we just encourage cultural humility and ask, what do you prefer? So let's talk about areas of competence. All right. So the next stage of this presentation is going to be focused on the 8 areas of rehab psychology intervention, where rehabilitation psychologists, if you get boarded, are required to show competence in. Okay. So I'm going to talk about each of these areas with respect to cognitive behavioral therapy, mindfulness, and potentially some other interventions that have been used with individuals with disability. And if anybody has questions, like please feel free to jump in at any time, or you can save them to the end. That's fine too. But I'm going to try to sort of parse apart each of these. So I'll break it down into the individual, family, or caregiver, which is a really big focus nowadays. Behavioral management, sexuality, vocational issues, pain I will touch on, but that's a very large topic that we could do a whole nother presentation on. Substance use, and then I'll briefly spend some time on cognitive remediation and modifications that you can do to your interventions, depending on the problem. Okay, so let's talk about individual treatment. So there are some common psychotherapy concerns with individuals who are coming after they've had a life-altering illness or functional change. They can, depending on what it is, whether it's a traumatic brain injury or a spinal cord injury or a stroke or a limb loss, it can really throw people into a bit of a spin as to who they are and what makes sense for them. So a lot of times individuals will report grief and loss of who they used to be. They will find that their relationships and their friendships are no longer the same, or they don't feel that they're the same. If, for instance, you were independent lawyer in the community and all of a sudden you ended up in a car accident and a spinal cord injury, and you can no longer feed yourself, and your wife has to feed you, or somebody has to feed you. That loss and now that dependency on somebody else to care for you can change the whole relationship, your friendships, and your feelings of personal autonomy and independence. You can see that one is a big one down there. A lot of people struggle with that. People talk about, well, what's the purpose or meaning in my life now, and how do I stay gainfully employed? How do I financially stay afloat? And all of the life dreams and goals that individuals have had, and sometimes they can be altered. Working with someone right now who is like, oh, I really want to go to Paris next month, but she just had a life-altering stroke. And so, there's just a lot of potential changes. And then also intimacy, like what does closeness look like after a life-changing event? So those are like the functional challenges that can affect someone's life. But there's also another important aspect when we talk about adjustment to disability, which is the societal, the attitudes, the environmental barriers, the stigma and bias that is out there. And I think we as a society are getting better about talking about it. But it's something that we still need to improve, because individuals with disabilities face these biases and stigmas every day. And it can be very challenging, and I'll talk more about that. But when it comes to adjustment, how to address these potentially internalized biases in therapy. So let's talk about CBT. I think CBT is kind of like the gold standard that most people feel comfortable going to. And so just basic definition, CBT cognitions occur at a number of levels and can operate at a fundamental level. And they're typically outside awareness and give rise to the immediate beliefs in the forms of rules, attitudes, assumptions. And I think we are all aware that sometimes those beliefs and assumptions are not accurate, or maybe if they are accurate, they might be maladaptive or rigid, and maybe not helpful. So, what does this look like with adjustment to disability? Well, let's look at this case. An individual who has what I would say is internalized standards that are maybe typical um, of beauty, a standard of beauty, that are defined by the non disabled world, might believe that is the ultimate beauty standard that is attractive, and that she must look as non disabled as possible. Well, if she suffers from some sort of injury, she loses a limb, or she has to use some form of equipment, like if she's in a wheelchair, this could significantly affect the way that she thinks about herself. These thoughts can result in challenging emotions, and that ultimately she could end up with, withdraw, not engaging, and hiding, or not living her life to the fullest. So this is just one example, but it's a very common example um, that I find, particularly here at the hospital at this stage of adjustment. So the medical model of CBT came out, and it has some problems, but I just want to show this to you because this is how, if we look at the prior case, this is how it would have been approached. It would have been, well, here are some cognitive distortions that, a CBT therapist could look at. Well, maybe the individual, the woman, has a negative view of the world, or maybe other people are just insensitive, that she has the perception of rejection based on using a wheelchair. Maybe she feels hopeless, or there's some sense of personal entitlement that she's special and needs more. And feelings of vulnerability, in that individuals with disability are at increased risk for poverty and may live in high crime neighborhoods, thus increasing their vulnerability and potential for victimization. So this is a medical model of CBT that was in use for quite some time. However, there's a problem with it, and I hope that you can see what the problem is. And the problem is that the medical model of CBT places responsibility for the distorted thinking on the individual with disability, and it doesn't really connect to the social fabric that this person is living in. So the disability is kind of viewed as a defect of the individual, and that sort of almost needs to be corrected, and that's not, I think, being promoted at this stage. However, it was viewed like that, and so now we're looking at CBT and looking at these cognitions within a disability framework. And we're really starting to focus on the societal factors that need to be considered. So, including things like prejudice, oppression, marginalization, and particular stigmatization. And if there are distortions, which there can be, that I'm not saying there aren't distortions, but it can be helpful to address them from more of like an interactionist perspective. So, for example, people with disabilities experience this increasing marginalization and discrimination, and that may contribute to the risk of cognitive patterns that we may label as distortions. Um, but and they may have been internalized in ways that could be harmful. So it's really hard to say, but society is challenging because it's difficult to avoid because of the pervasive messages that the society can kind of give to the individuals with disability. And in our culture, there tends to be this prizing of perfection, and that bodies that are quote unquote not normal are seen as less desirable. And so the role now that we're looking to do with cognitive behavioral therapy is to help the person recognize and challenge these societal derived beliefs while recognizing that these distortions are really coming from problematic social conditions. Now, it can be a balance, right? You may find that it is a challenge within each individual's scenario. Um, but we're really trying to consider that what people are going through is playing a much larger role in their quote unquote cognitive distortions. So that's the CBT model. But now I want to introduce a different kind of model, and that's mindfulness. And I hope that you have had some experience with mindfulness or at least have heard of it. I know it's pretty popular. Um, But mindfulness is according to Thich Nhat Hanh, is the capacity to be aware of what is going on and what is there. And the object of your mindfulness can be anything. So Thich Nhat Hanh, if you're not familiar with him, he's a Vietnamese Buddhist monk. He's a global spiritual leader and is an activist. And he actually recently had a stroke, and I believe he passed away. But he is a wonderful writer. So Um, John Kabat-Zinn took Thich Nhat Hanh's work and he developed something called mindfulness-based stress reduction, which you may have heard of. It's MBSR. And he developed it in 1979 at the University of Massachusetts Medical Center. And it was based on the idea to help people with chronic pain, basically individuals that doctors had given up on. And what John Kabat-Zinn really focused on was that it is possible to investigate and transform your relationship to discomfort or whatever it is in any time and place. So it's even if you're in pain, that you can transform that relationship into something that may not necessarily reduce the physical pain, but can reduce the suffering. So John Kabat-Zinn defines mindfulness as paying attention on purpose, in the present, and not judgmentally to the unfolding of experience moment by moment. Um, this is actually a fantastic definition, and it's broken down into a couple different parts. So I don't want to beat it up too much, but I do want to say that paying attention on purpose is very challenging alone. We have a lot of competing demands out there. And so it's done with intention. And it's done with intention to this moment, not last moment, not the next moment, but just this one. And the trick is non judgmentally. And the mind is often judging things regularly. So being aware of the judgment is part of it. And then continuing to do that to the unfolding of your experience. And so this takes quite a bit of practice. However, what we are finding is that the practice of mindfulness is really been quite effective at enhancing mental health. And it's been applied to a variety of different things. So everything from job performance to social skills to reduce employee burnout, to decrease um, turnover and problematic drinking, anxiety and depression. So it really has been quite effective in a variety of different areas. And the I should say two, there's many, there really are quite a few now. But the two that I'm most familiar with um, are mindfulness-based stress reduction and mindfulness-based cognitive therapy. I'm certified to teach both. Um, and so I've done like several silent retreats and a lot of meditation, and I find it to be a wonderful practice just personally. But I do find that they're also useful. Now, the difference between the two is subtle, but it's important. So, MBSR, the initial mindfulness based intervention, was again built off of the idea of tolerating difficult pain based sensations and emotions. So it's really focused more on, um, I would say, gentle yoga, unhelpful reactions, and then accepting and not judging your experience. MBCT replaces some of that content in MBSR with a focus on the cognitive aspects of depression and some of the behavioral aspects as well. But it's more of the cognitive. And then so there are pieces that are kind of missing from MBSR that are replaced by MBCT. But they're both I think they're both very effective depending on what the issue is that the individual is trying to work on. So when we think of mindfulness as an intervention for individuals with disability, we have found in the research that just like it's enhanced other individuals' ability to cope, it also enhances those with a disability. So whether you have MS or epilepsy or traumatic spinal cord injury or traumatic brain injury, it can enhance your ability to live with illness. And so we have a variety of different research studies, and I don't have to go through all of them. But I also want you to know that it's not just um, TBI or stroke. It also can relate to like other illness in general, including cancer, restless legs, fibromyalgia. And so, I think that just in general, when we think of coping with illness, mindfulness or mindfulness intervention seems to be a very highly effective way of helping people manage the stress of chronic illness. And why is that? Well, so intervention using mindfulness tends to help people focus on the self compassion when they may have been treated in an offensive or hurtful way. It can help with the forgiveness of oneself if, particularly, if you were the one driving the car and, and there's maybe some guilt or shame behind that of your injury, as well as resilience. It can help with the future management of stress. It can help with self soothing. So when somebody's having a hard time, like emotional regulation, when they're feeling really anxious or upset, as well as, again, that compassion with being imperfect and being able to handle the strong emotions that often emerge as part of the adjustment to disability process. So now that we kind of covered that, I would like to move on to adjustment to disability within the family. And when I say family, I use this term pretty broadly because family can be a lot of different things. It could be a professional caregiver, it could be a friend, whoever is helping in caring for the individual. And I think it's important to know that caregivers have often a hard time managing the stress of giving to somebody and also taking care of themselves. So if your spouse all of a sudden needs 24-hour, 7-day a week care because he needs to be moved or showered or toileted or dressed or fed, and the spouse is now in charge of all of that, a lot of times, this new role, this new obligation, or this new joy, sometimes people say it can be joyful, but it can be a stress. And so caregivers often report somatic symptoms, depression, relationship challenges, isolation, and also reduced economic opportunity. And depending on the caregiver's coping style, whether like pre-morbidly, like they had like an impulsive or they were very passive, um, it can be negative. It can kind of result in a negative outcome with the patient. So patients can have a harder time recovering depending on the caregiver's coping style. And what we know is that mindfulness intervention has been shown to reduce caregiver burden. And there are more studies on the way with that. That we know that one shows that can be helpful. I personally find that psychoeducation, so providing a lot of education about illness and injury, can be helpful. But the literature really speaks to problem solving as the main way to help individuals who are caregivers. And so they say that problem solving training, which focuses on what's called the perceived burden and stress of caregiving, is the most helpful or the most efficacious way to help caregivers feel more confident and less stressful. And so problem solving, if you're familiar with problem solving training, seeks to build skills, right? So you work on identifying the problem, goal setting, generating solutions, different kinds of decision making, and then implementation and reviewing it, right? One of the most effective caregiver programs that I really enjoy is called Powerful Tools for Caregivers. They did not pay me to say that. I have no conflicts of interest. I just happen to really like that one because it's online and you get a book, and it can. I find that caregivers really enjoy it. So let's talk about behavior management now. So behavior management is another area of intervention that I'm not so sure that I don't know how much you have to deal with this as an outpatient clinician. Um, I'm curious to hear afterwards if this is an issue. I'm definitely curious what your experience is like. But here on an inpatient level, we have a lot of challenges with behavior management. And so I'm just kind of going to review some common situations. And so, for instance, like after a brain injury of any types, and you often get what's called disinhibited behavior. So that can be like a low frustration tolerance or inappropriate social or sexual behavior or language. Or it can be somebody who just literally cannot stop talking. I have a few individuals right now who cannot inhibit their ability to speak. And so I had somebody who can't inhibit their ability to sing. And so she just sings all the time. And then the opposite of that is what's called inhibited behavior. So this lack of ability to engage, right? That lack of initiation, motivation, or engagement. And you obviously have like person specific factors. So if there was like a pre-morbid coping style or mood related issue, that can be exacerbated after an injury or illness. And then the characteristics of the injury. So depending on if you have like a brain injury, what part of the brain was impacted, right? Or was it a frontal injury, or was it, occipital, and in the sense that maybe their vision was impaired? If it was frontal, are they having trouble with judgment and impulsivity? So just noting what kind of injury they have. And then the environment, right? So here in the hospital, the environment can be full of rules. And so unfortunately, um, when you have a really heavy rule-based environment, that can be really challenging for somebody who has impulsive behavior. And so that can exceed their ability to cope, or maybe it's just overstimulating, right? And then the outcome. So outcome can either be reinforcing of behavior or not. And so we always want to look at that. And so if you're familiar with the basic behavioral management, it's the typical ABC model. So antecedent behavior consequence, right? And the hardest part is typically identifying the antecedent, but like we clearly define the target behavior, and then we look to understand potential antecedents and consequences. So here in the hospital, an example is like a patient threw a urinal on a nurse at the bedside at 9 a.m. during medication administration. And so we want to look at the time of day, the location, the tasks, the person involved, person's mental status, emotional state, and the consequences that may be reinforcing. So yelling results in increased attention from the staff, skipping therapy, and avoiding the painful exercises, right? So we would want to work on trying to figure out maybe potentially less painful exercises or a more rewarding experience um, in therapy so that we could potentially avoid throwing things at nursing. So that's one idea. But it's important to look at it on a continuum, right? So some patients are going to be able to handle more advanced interventions versus other patients who may have more cognitive challenges or other challenges. So if the person is more autonomous, they might be able to handle more like metacognitive or self-regulatory strategies versus if the person needs more of like the environmental management, other people managing the environment for them. Like maybe we need to close the windows, turn off the lights. We need to keep the stimulation very low because the person becomes overstimulated very easily. All right. So let's just touch on sexuality. I think this is a really great topic because despite illness or injury, most individuals with disability maintain their desire for closeness, affection, and sexual fulfillment. And there are unfortunately a lot of obstacles, whether that's societal or personal. Individuals with disability report that it's much more difficult to find a partner, and they also find lower satisfaction with their dating frequency. And so, as a provider, a lot of times people are unsure of their role in delivering sexual health care or addressing sexual concerns. And so that often means they go unaddressed. Um, but I encourage you that this is an area that we can really offer a lot of potential guidance or at least open the door for future conversations. So there's a wonderful model. It's called the explicit model. Okay. And originally it was just the plicit model. So the X was added in 2006. So it's extended permission. So originally it was just permission to get the permission of the individual to talk about sexuality or their interest in sex or their ability for intimacy. But what we were finding in the research is that people were sort of like glossing over just asking permission. So the extended permission is really checking in with the person, being like, is this something you want to talk about? And if it's not, then there's no need to address it at that time. But continuing to ask for permission to discuss this if the patient is interested. And then if they are and they do bring up concerns, the initial approach is just providing limited information, right? So if somebody has a spinal cord injury, a high level spinal cord injury, but they still want to engage in sexual activity, what does that look like, right? And there's a whole research literature of how that happens and what people can do to engage in intimacy at different levels. But you start off with limited information. And then if they're open, continuing to ask for permission, then that's when you can provide more specific suggestions. And at that point, intensive therapy would look, even if they're interested, like, hey, I really do want to have sex, but I can't maintain an erection. How would this look like? What would I do? That's when you can refer to a urologist or you can refer to other specialties that might be able to help this individual in a different way. So the goal really is to increase the communication among patients, their partners, the healthcare team, and challenge the notion that sexual expression is unimportant or secondary and or is only for typically abled individuals. So I think this is an area that we can certainly improve upon. The next one is vocational issues. I won't spend a lot of time on this, but vocational counselors are really important individuals, and because individuals with disability often experience so many barriers to entering or re-entering the workforce, and they're much less likely to be employed by their non-disabled counterparts, as well as live below the poverty line. So vocational counselors have their own training and their own services, but we can collaborate with vocational counselors. We can do things like supported employment, where we work with the vocational counselor or community team to help people re-enter the job force. And it might look different. It might not be the same job, but it is really helpful to get people re-engaged and work with the vocational counselor. Regarding pain, I'm only going to just briefly touch on this because pain I could just do a whole nother presentation on. It is so common among individuals with disability and chronic health conditions, and it is a really complex interaction of biopsychosocial factors. Things that have been helpful for managing pain are relaxation training, CBT, mindfulness. They're all different aspects of helping to manage pain. But again, I won't get into the specifics because I think it is a really complex conversation that I would be happy to come back and do another presentation on. But it is an area that we certainly need to provide support on because individuals have a lot of trouble with pain out there. It's very common, very, very common. Then the last area that I'm going to touch on is the substance abuse and health behavior. So many times alcohol or drug abuse is comorbid, and it can be really challenging to adopt a healthy lifestyle or quit harmful ones after you have a disabling injury. So what we know from the literature is that motivational interviewing has the most scientific evidence to be used with people with disability, but CBT and mindfulness-based substance relapse prevention are also very popular in non-disabled populations. And so when you take a treatment that hasn't been used with a certain population and you want to modify it to working with somebody who does have a disability, I'm going to briefly cover some modifications. And so these are just general, very like 1,000 foot kind of quick modifications that you can make to your interventions depending on what the issue is. So if somebody presents with a disability and they're having trouble with motor, you can consider telehealth or use voice activated smartphones. Attention is minimizing distractions or breaking it down into smaller chunks. Memory, we tend to try to promote the use of a notebook or digital recorder. Language, we try to minimize jargon using pictures, yes, no questions, things like that. And for processing speed, we try to speak much more slowly. And when executive function is a problem, we try to do like practice turn taking or one topic at a time. Impulsivity, we try to develop a metacognitive script. So, like, stop, think, act, which is very challenging, but it can be helpful. And then initiation, if getting up and engaged is the problem, then we try to include the family and try to create more like tasks that have intrinsic meaning. If fatigue is a problem, we can shorten our sessions. And if emotional regulation is challenging, we try to work on modeling our own calm behavior and focusing on distress tolerance skills. And so, if that is something, if you like kind of using modifications, I think you might be interested in what's called cognitive remediation. And cognitive remediation therapy involves the use of behavioral strategies to improve the span of cognitive processes and overcome related cognitive challenging tasks. And if you like that stuff, ACRM, the American Congress of Rehabilitation Medicine, offers a great manual and a 12.5 CEU online course. So, really helpful. And there it is, like they just came out with a second edition, so it's really great stuff. So in summary, I'm just gonna say that we touched on a lot of different things, everything from adjustment to disability, individual, family, talked about behavior, sexuality, vocation, briefly touched on pain, but lots more on that, as well as substance abuse and modifications and cognitive remediation. So there's like 2 minutes left, and I just want to open it up for questions.
Hi, I have a question. In one of the slides, you had mentioned disability and culture. And I'll just, if you could go back to that slide just a little further. I'm not too sure which, it was at the top. I know it was like way further at the top. And it pretty much stated about,
This
yeah,
one?
your disability, it's like diversity. And then there was one about culture as well.
This
And
one?
yeah, disability is a cultural experience rather than merely a medical status. And so I was very intrigued about that cultural experience aspect. And if you could kind of like just.
Yeah. So Dr. Erin Andrews is leading an initiative that describes disability as more of a cultural experience based off of different social constructs in the fabric around an individual versus just the diagnosis. So for a long time, this is her definition, but I would say that I agree with it. For a long time, disability has been viewed as just a medical illness, like an injury, right? And it didn't take the whole person into consideration. And so it was a very medicalized, limited approach. And I think it isolated a lot of individuals, and we really missed the boat as as a society and as a field. So I don't know if culture is maybe the right word, but I do agree that we missed the boat on really looking at people as holistically. And that it's not just an injury, but it's what the injury means to them and what their societal resources are. If if somebody loses their job because they had a major injury and now they are in a wheelchair and they're living in poverty and they can't return to their work, and then they come in for therapy and we say, oh no, this is just in your head, right? Like, no, these are real issues that people are facing. They are at higher rates of being victimized and they are at risk. And I don't think as a individual, I think it's our ability to say, no, this is like a legitimate problem. How do we help you advocate and get what you need? So that's where I'm coming from. Does that make sense?
Yes, thank you for clarity. Thank you.
You're welcome.
Dr. Hammond, I had a quick question. You mentioned found very interesting the problem solving training for the perceived burden and stress on caregivers. I know that's a big part of the equation as
Mhm.
well. And I was curious about that online book that you mentioned for
Oh,
care.
the powerful tools for caregivers.
What's it called?
Powerful tools for caregivers.
Okay, yes.
There we go.
Thank you.
This one.
Yes. Okay, thank
Yeah.
you.
No, I find that to be a really great because it has like a support group involved as well.
Yeah, that was my other question because I'm very interested in grief work. So I was wondering if in the acute or subacute phase, if you're in your experience, you see like built-in processing groups for family and individuals to, like you said, like process some of these real issues that, like you said, it's not just in their head. Like I know a doctor who had a bike accident. Now she can no longer practice, like what that looks like, for someone who had experienced such a loss across probably more than one area, but I find it like very fascinating. And I would imagine that would be something that maybe would be built into the program.
So for caregivers, it's a little bit different. But I do encourage you to go to caregiver.org and you might find what you're looking for there. That's a really comprehensive caregiver website that offers support groups as well. But it also offers a lot of other resources.
Thank you.
You're welcome. Other questions or concerns, or I'm happy for like disagreement as well. Anyone, it's okay. I'm really open to any issues or questions. No?
Dr. Hammond, I have one more thought about the polytrauma. I've never heard of that concept, so that was really interesting to me. So that's just like would that be example of like somebody who had multiple injuries or like a very serious accident where there's like so many different layers and levels of support and intervention?
Yes, absolutely. Absolutely. So, like, if you had a brain injury as well as a loss of your limb or a spinal cord injury, in addition to maybe like you had major surgery in your abdomen or like from some sort of accident. I mean, I'm just giving you a potential example, but it could be a whole host of things. Usually they come in off of having some sort of major accident, like whether it's a bike accident, a car accident, motorcycle accident. That's typically when I see the polytrauma.
Thank you again.
You're so welcome.